Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and eating should be simple. Food goes down, you enjoy it, and you move on. But for people with EOE or
Eosinophilic Esophagitis.
Why you guys make me say
It's
the
not that
hardest
bad.
words for this stuff?
Just say EOE.
All right, I will. Because of this condition, swallowing can feel difficult, even scary. And apparently it's a condition that's showing up more often, and a lot of people don't realize that they may have it. So today, Dr. Issam Turk is back with me. It's been over a year since you've been in here, so I don't know why you've been avoiding me. I don't know what the deal is.
My EOE has been acting up.
You just haven't been able to roll in.
Food's been getting stuck.
All right, I get it.
I've been having a difficult time.
You are, of course, a gastroenterologist at Monument Health, and hepatologist as well. We've talked with diverticulitis with you in the past. What other topics have we covered? I don't quite remember. I should have looked back and saw, but
what did we cover? IBD and IBS.
Yep, whole, and I'd love for you to go back and listen to those podcasts because they're super informative because you know what you're talking about.
Half the time.
No, come on, man, all the time. All right, I want to talk about this because this is the first thing today I learned about it. Didn't know this was a thing. I've known people that have had the link system put into their esophagus.
That's different.
For a whole different reason.
That's completely different, yeah.
But sometimes they'll have that trouble swallowing.
Sure. Well, that's induced by a foreign body that has been placed,
This is just
this is your
own body.
Yeah, exactly. So dysphagia, which basically is a term, it means difficulty swallowing, could be caused by a lot of things, right? I mean, there's a lot of things that cause difficulty swallowing in people. And that's actually when someone has dysphagia, difficulty swallowing, that right there is an indication to getting an upper endoscopy right away. You know, you'll hear a lot of gastroenterologists, they say that we like to scope a lot, and then, you know, you go to a GI and you tell them that, you know, your scalp is itching you, they'll scope you, they'll any reason, right? And even no reason at all, but this is actually one of the clear-cut indications to getting an upper endoscopy right away, because it is not normal to have difficulty swallowing. So if someone has difficulty swallowing, whether they're a little kid or they're a 100-year-old person, that needs to be evaluated. So that's the most common symptom. Okay, so whenever you hear dysphagia, right away that warrants a workup. So if someone's having difficulty swallowing, you got to see a GI. Ultimately, they need an upper endoscopy.
So when you say like difficulty in swallowing, what does that mean?
So that means the typical person who does not have any issues able to just chew their food as long as they're chewing their food properly. I mean, now if you take a whole hot dog and don't, so it could get stuck, right? But this is not to be confused with choking. People always confuse the two. Choking is when something is obstructing your airway, right? You get something and then that you could die right then and there if the obstruction is not cleared. Dysphagia or difficulty swallowing, it just means that you take in the food, whether it's solids or liquids, and it just does not go down right. So your esophagus, which is your food pipe, its job is to get food from your mouth, you chew it, and it goes down. The esophagus is three parts, the upper, the middle, the lower. And then the upper part you have control over. It's composed of skeletal muscle. The middle is both skeletal and smooth, so a little bit have control. And then after that, you have no control. And then you just rely on your esophagus to get food down to your stomach. And then the stomach gets broken down and on its way to the small intestine to get absorbed and digested and whatnot. So dysphagia or difficulty swallowing, that means that things are not going down right. So you eat, you chew your food, and then it just gets stuck. Or you feel like it's just somewhere in your chest or in your esophagus. And sometimes it goes down. Other times, you ever happen where like you're eating fast and like you take like a big bite and then it's just like going down and you feel it kind of like stuck a little bit and it feels like someone just stabbed you in the chest. It's very transient and it goes down. Well, imagine if that happens all the time, and imagine if that happens to the point where it actually gets stuck and it doesn't go down at all. And then you just have to either vomit it up or hope that it goes down. So that's what dysphagia is. That means that you're having difficulty swallowing. The food or the liquid is not going down. Now,
it can happen with liquid too?
So exactly. So that's my point. So with dysphagia, when we get a history out of someone, when someone comes, we get a referral from a primary or a patient just comes, saying, I'm having swallowing issues, we ask a lot of questions. But the first question we ask is is your swallowing difficulty, is it with solids, liquids, or both? And the reason we ask that's a very important question is because solids, it makes sense. If there's a blockage or something like going down, then solid food will get stuck, right? Liquids, technically liquids should just go down, right? And even if you have a obstruction, unless it's a complete mass that's blocking, which that wouldn't happen overnight. But sometimes patients who have a motility disorder, which means a problem with the contraction of the esophagus, those patients can have difficulty swallowing with even liquids, right? Because your esophagus will, for example, spasm, or it just basically won't relax properly, and then the liquid even won't go down. Specifically, and then dysphagia is a whole topic in and of itself. And like I said, there's a lot of issues that could cause cancer, strictures, ulcers, motility disorder, like we said, fungal infections, esophagus, a lot of things, right? Specifically with EOE, which is what we're talking about is today, the dysphagia or the difficulty swallowing is with solids. You'll almost never hear of someone saying that their liquid, their food, their water got stuck. It just doesn't make sense, or like their juice just did not go down and it came up, right? So it's solids. And what EOE is eosinophilic esophagitis. It's basically like an immune-mediated problem. It's also kind of like an allergic problem, but it's not a true allergic problem. It's very complicated. Basically, eosinophils are specialized types of white blood cells that are not meant to be in your GI tract. When they make their way to the esophagus, which is where they shouldn't be, then over time, that causes inflammation, and that causes remodeling of your esophagus. Your esophagus actually starts changing in terms of its shape and its appearance, and ultimately the function of it. And this is basically, we feel that it's certain foods that will trigger it, and then there's other environmental causes that can contribute to it. So when eosinophils start making their way to the esophagus, which is where they're not meant to be, then over time that causes just an unnecessary immune reaction, and it causes inflammation. And over time, these patients will develop these dysphagia issues and swallowing issues. And it happens early on. And a lot of times, the patient will think that this is just, it's normal for them. So they'll tend to eat very small bites, and they'll eat very slowly, and they'll kind of get used to it up until they end up in trouble. And this is how most of the time we diagnose this. It's in the acute setting. This isn't like, where like you have a cut and you see it and you want to go get it checked out, or you're having like, difficulty breathing all the time. This is something where most patients, they just deal with it and they think it's normal up until they're in trouble. And when are they in trouble? Is when they end up with something called food bolus impaction. And that's one of the GI emergencies where we have to go in the middle of the night or whenever it happens. That's when typically it'll be a piece of steak or chicken or pork. It's meat usually. And they didn't chew it well, or they did, and then it gets caught and it gets stuck. And the symptoms are miserable. So they feel like there's something in their chest and they're having pain, and they start drooling. And this is how when the ER calls and say, hey, we have a food bolus for you. And like, oh, all right, we have to come in. So this is actually an emergency. So even though it's not in the airway, I mean, that's an absolute emergency. Someone could die. This is in your food pipe, right, in your esophagus. If you have something in your esophagus that's causing a blockage, that's a big problem. Number one, what happens is, and this is how we know it's legit, they'll be sitting in the ER and they'll be holding a basin or a cup, and they're just constantly spitting in it. That's how you know it's a legit case of food bolus impaction. Because why does that happen? The food pipe has been blocked because now there's a piece of steak or meat in there, and it's not going down. So your saliva that's being produced here in your glands, in your glands. So the saliva gets produced, and you either spit it or you swallow it, right? As right now we're sitting, you're producing saliva and it's going down. You don't even think about it. But then when there's a blockage, the saliva goes down. It's like dead end. There's construction, Sheridan Road, and then it starts coming up, and then you keep spitting it because it's not going down, right? So that's happening because there's a blockage. So then sometimes they'll jump or whatever, it'll pass. A lot of times it doesn't, and that's when we have to go in, and they get intubated to protect their airway, and we go in and we see it. We either try to push it down, or sometimes if we can't, we have to pull it out and we remove it. And that's how we diagnose. Usually that's how we catch the diagnosis.
You were talking about, let's say people, this happens and they're eating somewhere and they don't have quick access to a hospital.
Yeah.
What, can they jump up and down in some instances to try to help?
Yes. So the thing is, if you don't have a stricture, like an actual narrowing that's distal or below that level, then they could actually, one of the tricks that I do recommend when they call me in the ER, because I'm lazy and I don't want to go in. Of course, like I go in if I have to, but I'll say, well, give him glucagon. It's a medicine that will help kind of relax things. And then I tell him, and that works in my experience about 20% of the time, no joke. And I tell him, give him pop or soda, depending on where you're from, and then have him take just one gulp, just one sip of it. And as it's going down, jump. So that way the fizzing from above with the forces of gravity will allow it to go down, right?
Yeah.
So at least and sometimes that works, and they'll feel it right away. They'll know, it passed. They'll know, because all of a sudden they have this relief where there was something blocking here, and now I feel better. They'll still have some discomfort because there's esophageal irritation that happens, but they'll feel it and like, all right, well, he passed it. That doesn't mean they're good. So that means they can go home to that, but then they need to get in and they need to be scoped and diagnosed to see what is it that they have.
Yeah, don't take that as your fix.
Do they have a cancer? Do they have a mass? Do they have an ulcer? Do they have a stricture? Or do they have EOE?
Right.
Or do they have a motility disorder, etc.? So EOE, usually it's in the literature, the typical EOE patient is a young to middle-aged Caucasian male. There isn't that many of those here in Rapid City.
Hardly any.
So yeah, barely. I mean, I remember the last time I saw a white guy in this town. So that's typically your demographic, right? So that's number one, why it's coming here. Number two, Rapid City, again, here in South Dakota, it's a dry climate, and it's felt that in this type of climate, then it's more likely for eosinophils to make their way to and that's one of the thoughts, because I practiced in Michigan before, and I told you I used to see maybe one case a month, maybe less. Ever since I've been here for almost 2 years, and then this condition is getting increasingly more and more common, and it's all across the world. And it's 1 in 2,000 Americans have this, by the way, and it's becoming more and more common. But here in Rapid City, ever since I joined this practice, I get anywhere from 2 to 5 new diagnoses every week. And I'm a busy guy. I do a lot of procedures, see a lot of patients, but still, that is not normal. And I'm not even joking, and this is not even a HIPAA violation because I'm not saying names. Half of the anesthesia department are my patients, and they have EOE, because they'll see what I'm doing, and because they're the ones they're putting the patient to sleep. And they'll be like, well, Dr. Turk, I think I have this. And then I'll scope them. They do. It's either them or their spouses, whether it's the CRNAs or the physicians. And within actually my circle, in my practice, some of the people they have it. So it's so common in this area. And it could go from mild to moderate to severe. Severe, when they're miserable, they would know. But there are a lot. So this is the thing, to get out of this whole talk, if you or someone you know has issues swallowing, get it checked out, because it is not normal for your food to not go down. It should go down smoothly. Your esophagus should be a smooth slip and slide, pathway for food to go down. If you have issues where food sometimes gets stuck, get that checked out, because the earlier that you catch this, the better, because there's a lot of things that we could do for it.
What if it's not caught early?
Then over time, like I said, remember I told you the inflammation, all that, you develop remodeling of your esophagus.
Scar tissue?
Yes,
Is that what happens in there?
thickening, scar tissue. It's strictures and thickening that form and rings. So your esophagus, so the patient who has EOE or eosinophilic esophagitis, their esophagus will look ringed. You would think that you're in a trachea, because the trachea, the air, the pipe, to the airway, or the windpipe, that is ringed. The esophagus will literally look like a trachea, and the term is called trachealization of the esophagus. So the esophagus will look ringed, and be like, oh my God, right away, as soon as I see that, I know right away this is EOE. But then there's different levels, right? Sometimes they have a very thin caliber esophagus. Sometimes they have strictures. Strictures are thickening and narrowing that happens, and that's over time because of this condition has been gone unchecked for a while. And sometimes they get these furrows, and they get these white plaque and exudate. So there's endoscopic features. So first there's the symptoms that will get you through the door. And then there's the endoscopic features, which is what I see when I'm in there. And right away, I could tell. And then the way you confirm the diagnosis is by getting biopsies, okay? So remember how I told you eosinophils should not be in the esophagus? Well, you take biopsies from the lower esophagus and from the upper esophagus, and you separate them. If you have more than 15 eosinophils per high power field, which is a diagnosis made by the pathologist, boom, you have EOE, okay? Now, sometimes there are some conditions that can give you falsely elevated eosinophils, or it could present like EOE and just like good old-fashioned uncontrolled acid reflux disease. So if someone has really bad acid reflux and you just biopsy their lower esophagus and they have like a mild increase, sometimes they'll call it EOE, but it's not. That's reflux because of inflammation, right? But EOE is when that's why you want to separate the upper and the lower, because the upper should not have reflux. You know what I mean?
Right.
You should not have acid going all the way up unless you have like a massive hiatal hernia.
You shouldn't feel it up here
Exactly.
in here.
Exactly. Oh. So that's how you get the diagnosis. Endoscopic findings is one thing, but you confirm it by getting biopsies. And once you have the biopsies, boom, you amongst every other person in Rapid City, you have EOE. and then we talk about treatment.
What is the treatment then? What do we do for it?
So for the longest time, we were very limited with what we could do for EOE, okay? For the longest time, it was felt to be like an acid reflux type disease that acid is bringing it on. And then 30-40% of patients will respond to antacids. You'll put them on twice-a-day dosing of antacid like omeprazole or whatever. And 30-40% of those patients, they'll do okay and they'll feel better. And then you scope them again a couple months later and you rebiopsy and you see, I'm like, oh, good, your condition's responsive. So we call those PPI responsive EOE. So proton pump inhibitor or antacid responsive EOE. And then there's more than half that don't respond to that. So then we do topical steroids where like budesonide or fluticasone, like the inhaler that you use for asthma, and you swallow that to help coat the esophagus. And that works in some group of patients, but it's just nasty and it's kind of annoying and patients don't like to do it. And then there was this whole thing, because it's felt that this is caused by certain foods. And there's 6 groups of food. There's dairy, egg, soy, wheat, shellfish, and mainly dairy, okay? So there's this thing called the elimination diet, which is very challenging for patients to do. And then you tell them to eliminate all these food groups and do it for 2 months. And then after that, start slowly introducing to see what's triggering it. That could be very challenging for patients to do. I mean, it's a lot. I'm talking, that's a lot of different food groups, you know what I'm saying? So for the longest time, that's all we had. Now, 2023, there's a drug, dupilumab or Dupixent. That drug has been around for a while for asthma and for eczema, for like moderate severe asthma, eczema, nasal polyps, a lot of allergic conditions. And in 2023, it was approved for EOE. Imagine and this happened around the time when I was in practice, and I knew about this drug, and I was reading about it, because I had seen a good amount of EOE in Michigan, nothing like here.
Right.
And I would feel bad for those patients where you try all these different things, right? The PPIs, the elimination diet, the steroids. Then there's a good 30% of them that are miserable, that nothing's working, right? Another thing that you do is when they have those strictures, those narrowings, you dilate them. So you go in with a balloon, you dilate them. You got to be very careful because it's very stiff and sometimes it could be high risk for perforation. But for patients where all these other treatment options don't work, I'm telling you, and I'm not... This isn't like, I'm being sponsored by this company.
Of course.
But out of everything that I've used in medicine in terms of medications and therapies, whether I've done internal medicine, I've done GI, this has been truly the most effective, miraculous drug for a condition. Right now, I have 100% success rate with this condition. So for the patients where these other things don't work, when I put them on it, boom, because that basically is a biologic and it targets the problem at the core. And not only do they feel better, because most of the time these patients, Mark, most of them also have asthma, they have eczema, they have other allergies. If you're targeting your immune system at that allergic response to help minimize the release of eosinophils, you're going to feel better in general from an allergy standpoint. So these patients, they feel so much better and they're like, oh my God, I can't believe this is what it's like to swallow. Yeah. And I had a patient, and it really touched me. And he's a young professor. He came to me because, like I said, I'm like the EOE guru in town, not because I'm this brilliant GI, but like they just come to me. Right. EOE finds me, and then I'm like treating all this, and like So, and I have a good algorithm to follow, right? So he's like, oh, I heard about you, and then, I've been miserable, and they moved into town. And basically, he said for all his life, since he was a kid, he's struggled with this, and he's had an established diagnosis, and nothing has worked. And this is the perfect candidate for this drug because he failed dietary, he failed PPIs, he failed steroids, and he's miserable. And he just all his life he just eats very small because you can't just grab a burger and eat it. You have to chew very carefully. You have to just make sure food's not getting stuck. Imagine how depressing. In my opinion, I love food. I think food is one of the biggest pleasures in life, and you'll always enjoy food whether you're 5 years old or you're on your deathbed.
Right.
Most things in life eventually you become too old to enjoy. But food, if you can't enjoy food, what a miserable life that is. I would, oh my God, man, I would be suicidal. So basically, this guy was a young professional. He's just accepted it. And all his life, he would just eat very carefully. And he's had episodes of food bolus impact where he has to go to the ER. He had to get the food out. So I scoped him. And yes, his esophagus looked terrible. It looked like a blizzard in there. It was like Narnia. You go in and it's just like white spots and ringed and all these endoscopic features that we talked about. And I was like, this is full-blown EOE. I biopsied and the numbers were off the chart. It was over 200. And the pathologists give you an estimate. They're not sitting there like counting, but they give you. Right. So like, some of them, they have nothing better to do. But anyways, so it came back clear cut, textbook EOE, which I knew. A, he already told me he had that diagnosis. B, I suspected it. C, as soon as I scoped him, it was like, even like in his esophagus, someone like tattooed EOE. I'm just kidding. But anyways, it was so obvious. So anyways, I already told him, you need to go on this drug, which is the whole reason he came to me. So we put him on it. 3 months later, I scoped him again. First of all, I talked to him before. He goes, I feel amazing. I feel great, blah, blah, blah. I scoped him again. I swear to God, it looked like a completely different esophagus. And his number went down from over 200 from upper and lower to less than 3.
Oh, my goodness.
His condition was completely gone.
Yeah.
And he was like, I feel like a new person. I can eat. I could this. I don't have to worry. Gone. This guy felt like $1 million. And so many other, this was the most dramatic, right? But so many others where it's also like a drastic. So I'm telling you, to me, this has been so far the only drug in my experience. Right. I'm sure eventually I'm going to get someone, I'm going to jinx it after this podcast,
sure.
where I'm going to put them on it and it's going to get worse.
And nothing's going to happen.
Exactly. But no, I'm telling you, they either feel 90% better or like 100% better.
Now you're not, but you start with these other ones first.
Of course, for many reasons.
Because I'm sure people are going to come in, they're going to just be like, just give me the pill.
Yes, well, of course, I told you there's an algorithm, right? So first you diagnose, then you try PPIs, remember, to 30-40%, whatever. Then you try this, and also from an insurance standpoint, they want you, because this drug is expensive, they want them to fail all that. Now there's other places where you can go straight to that, but I'm conservative. I'm not, I don't right away go, you need this, you need that. But there are certain conditions that warrant certain treatments, right? And you have to, it's called escalation of therapy. So, so we'll try everything else, but I could usually tell. When I scope someone and I see like, oh, it's a little bit ringed in the biopsy, I could tell that they're going to respond. But when I go in and it just looks terrible, when they have all these other endoscopic features that we talked about, when they have rings, they have exudate, they have furrows, they have strictures, I know that eventually we're going to need this drug. But you have to go through that whole process before A, it's approved, and then B, also, what if they do respond to the others, right? Because you always want to be conservative at first. So then you put them on it, you do it once a week, and then once they feel better and you scope them again and you confirm remission or response to treatment, then that's it. You just manage them symptomatically and you see how they do. And you tell them, if you have any issues, let me know. Sometimes you have to go back in. If they have strictures, you have to stretch those out. But for the most part, they do fine.
So can it be what you would call cured?
No.
Okay.
At least we don't have enough data, but because I can tell you right now, I've had patients that they went off treatment and they came back with a vengeance.
Okay.
Yeah. So like I said, again, it's like asthma. Like, does asthma ever go away? Sometimes, as you get older, it gets better. But based on my experience, I haven't seen it where it just goes away completely, unless it's you really kind of narrow down what food trigger it is, and then you're just really very strict with that diet. But there are some patients where it's so bad that you really need to be on treatment.
Okay.
And that's the thing. Like I said, when they start developing these strictures, then that's when things can be rough, and you have to go in and you have to dilate them. We have different ways where we stretch the esophagus, but you have to be very careful because their esophagus is very sensitive, and it's almost like it's just stiff. And I could see it as I'm inflating a balloon. I could see it tearing, and these are like high risk for perforation. You have to be very, very careful. So that's why it's very critical that it's caught early and it's managed, because once you start developing these issues where there's remodeling of the esophagus, then it's like harder to manage, and then you're at risk of recurrent food bolus impactions and food getting stuck. And usually when it comes to food bolus impaction, it's almost always meat, and the reason is if you eat bread, even though it'll be stuck, eventually your salivary amylase in your saliva will break it down, it'll go down, right? But meat doesn't get broken down by your saliva. Like imagine, take a piece of steak right now and spit on it, see what happens. It's gonna stay there till the end of time, right? So get a piece of bread, keep spitting on it, it's gonna dissolve. Do you get it?
Yes.
So that's why, that sounds pretty nasty, but I mean, I don't know, I just thought of that. Don't go, next time you're gonna go to a restaurant, you're gonna start spitting on it. My doctor told me spit before you chew, and go ahead, just like shower. And then he also told me to spit on everyone else's food before they eat it, just to make sure it doesn't get stuck. But no, the meat though, that needs stomach acid to be broken down. So that's why it gets stuck in the esophagus, and that's why that's an emergency. Another reason that's an emergency, it's uncomfortable, but mainly because if the food bolus or the foreign body, the steak or the chicken or the pork or the hot dog, if that's stuck there and you wait long enough, then the tissue around it will start dying, and you could develop actually ischemia and necrosis, and you could perforate. So, for example, I've seen it before when I was in fellowship. Some guy, don't even ask me why, but he said that they challenged him for like him and his buddies, like hot dog eating contest. And he had like 20 hot dogs in a row, and then basically our hot dogs got stuck in his esophagus. For 2 days, he had the food bolus infection. He just kept like ignoring it. Eventually, he got to the hospital, and by the time he got there, he had perforated. They had to fly him out with a helicopter, University of Michigan. He needed surgery. That's a disaster. One thing you do not want to rupture is your esophagus.
Well, how do these
things that you don't want to rupture most things in your body, but one thing you really don't want to rupture is your esophagus. This isn't like your Achilles tendon. No. You rupture your esophagus, it's a disaster.
Well, how do these guys like Joey Chestnut? How do they do this?
Well, I can assure you that Joey Chestnut does not have EOE. That is a guarantee. Okay, this guy's got the most pristine esophagus. His esophagus, he got it from Six Flags. It's like a water slide. So, I mean, again, the normal esophagus is able to accommodate, right? Just like any other, just same way the rectum's able to accommodate. That's why people get freaking and do things. So your GI tract is able to accommodate to the point where you force it, right? But patients who have EOE, their esophagus is not very accommodating. Do you get it? So again, any person is able to swallow and do this, and Joey Chestnut. But if you have EOE, believe me, you won't be joining any hot dog eating contest anytime soon.
Any eating contest. Okay, so what I'm taking from this, doctor, is report it. If you have felt any of this, what we've just talked about right now, get to your doctor, because it's not normal.
100%. This is the biggest thing. When they asked me to come on this podcast, like I said, I'm drowning in EOE as it is. But the part of the story that I shared with you about the staff, and then it wasn't just to put them on blast, and I didn't. I'm not saying names, but it's just because it goes to show you how many of them, they've been living like this, and they see it. They're like, you know what? I think I have this. And then they do. So my point is, there are so many people living their life where they're having swallowing difficulty, and they think it's okay up until they end up with that emergency because that's how most of the time we diagnose it. They end up in the ER with the food bolus infection. Oh, you have EOE. Come, boom, let's fix you, let's treat you. So again, I can't emphasize this more. If you or a loved one or someone or whatever have difficulty swallowing, the food does not go down right, that is not normal at all. Now, there are some conditions where something called globus hystericus or globus pharyngeal, where they have a sensation like there's something stuck. That's different. And even those, we take a look, we see, I'm talking like food does not go down. They've had episodes where it's gotten stuck and they just vomited it up and it went and it cleared. Yes, you've gotten away with it. Eventually you won't. And it's important that you get evaluated. Because it could be a lot of things. But if you're usually a young Caucasian male, that has other allergic issues, most likely you have EOE, and let's get it checked out. But that's another thing. In the literature, the typical patient is a young Caucasian male. But something that's interesting, and I have a whole Excel spreadsheet where I have, because there's so many.
You seem like a spreadsheet guy to me.
Not really. It's actually my nurse that did it. Bless her heart. Her name's Summer. She's excellent. So she has, because we have so many patients, and we just basically like how many were when they were diagnosed, what they're on, and also for insurance purposes, because we have to show like when they were scoped, the initial diagnosis, the repeat, they responded to this, they failed that, blah, blah. So we have a nice spreadsheet, and I've looked at it, and in the literature, the typical patient is a young Caucasian male. Here in Rapid City, for some reason, it's almost 50-50. Men and females, so there's at least equal rights there. So, but it's still more males. But right. I want to say it's 60-40, really, if I want to be, exact. We're back in Michigan, where I practiced initially. It was almost every time it was a male.
What I'm starting to hear from this conversation right now, doctor, is just move to Michigan. Is that what I'm getting? Because
no, move to like Florida or somewhere humid. So like, because again, it seems like it's more common in drier, colder climates. Okay. I'm just saying, I practiced in Michigan and I saw it, but it wasn't like this much. Here, I'm seeing it nonstop. Okay. And it's truly very eye-opening, and it's overwhelming, and it's sometimes I'm telling you, like last week I had 7 cases between already diagnosed and follow-ups of EOE. I mean, that's in 1 week. So it's just crazy. It's very common here.
But guess who has job security?
Oh, I know. Exactly. That's what I'm saying. Hey, people are going to think I'm inducing it. I'm going to be some part of like some guy's going to get on his podcast, conspiracy theory, and say that I'm, sprinkling something, chemtrails in the air.
They're going to look in the kitchens wherever they're eating now like, oh, look, there's Dr. Turk.
Well, believe it or not, who knows? There are other environmental factors, so God knows what's in the air. But all I know is it's common here, and it's becoming more common, and it's a problem. And this isn't something like, oh, if you don't treat it, it leads to cancer. No. This is, if you don't treat it, A, you're miserable. B, you could get in trouble where food gets stuck, and then you could really rupture your esophagus. So it's an inconvenience, but it's also dangerous. You know what I mean? Unlike when we talked before, like about IBD, like ulcerative colitis and Crohn's disease, that condition, if you don't treat it, you could lose your colon or your small bowel, or you could get cancer, right? This, you're not going to get cancer, but your esophagus is going to get destroyed to the point where you're going to struggle more and more with eating and swallowing, and then things can get ugly. So again, and there's levels to it, and this isn't meant to scare people. No. I have there's mild EOE, there's moderate, and there's severe, right? But again, to reiterate, if you have, or if someone has difficulty swallowing, that is not normal, regardless of the age. Whether you're 12, it's very common in the pediatric population, by the way, which I don't see. But young, middle age, old, it is not normal. And it's usually, again, we catch it in younger, because, by the time you're 70, you would have known by then, because eventually it's going to happen. So most of the time, my average patient with EOE, I want to say, is about like maybe 26.
Okay.
Yeah.
Well, Dr. Issam Turk, thanks for coming in again, buddy. Don't wait a year next time, all right? This is kind of...
it's all the EOE.
I was going to say, I'm
drowning in eosinophils. Just tell people to move out of Rapid City.
Right, then, either move or just let them rest
or stop eating. Stop eating. Or spit on your food. Spit on all your food. But we said it doesn't work for steak. Go next time you go out with someone, start spitting on their bread.
Thanks, man.
All right,
I appreciate it.
Thank you.
You bet.